particularly neurologic. innovators, and these companies are pretty young still, but we're at 500,000, actually on the way to over 600,000 patients, and that number is increasing rapidly. So the process seems to be reproducible. So with that, let me introduce Mark Jervik, who was a student in our class, and he's going to tell you a little bit about a needs area and a technology that he and his team have developed and are bringing forward by means of a company called Materna.
Thank you, Dr. Young. So at Materna, we're developing a device to try to prevent some of the damage that women commonly suffer during childbirth. So when you think about damage that results from childbirth, most people think about tearing. And the reason is 80% of women suffer some degree of laceration as a result of vaginal delivery. Most of these lacerations occur in a region called the perineum, which is the region between the vagina and the rectum, and they're graded in severity from 1 through 4. So the greater the severity, the greater the consequences that arise from these tears. And so our original need statement was to try to find a way to prevent or reduce the incidence of these vaginal lacerations. But as we were investigating this need, we learned that there are a lot of things that obstetricians worry about during vaginal delivery, and preventing tears is something they cared about, but it wasn't high on the list. And we realized that developing a device only to reduce lacerations was perhaps unfundable or very difficult to fund. And we received imaging patients that came in with these pelvic floor disorders, and a large percentage of them seem to have this defect in their pelvic muscles. The muscle, one of the pelvic muscles seemed to be missing, and they hypothesized, well, this is probably something that happened during childbirth, and they started imaging patients before and after childbirth, and indeed they found out that greater than 30% of the time women are having an injury to this pelvic muscle that is now being linked to these problems later in life. And so we sort of redefined our need into not only trying to prevent lacerations during delivery, but can we prevent this pelvic muscle injury, which could then have long-term implications to mother. And these problems are sort of a lot bigger problems than most people think. 11% of all women in this country will have surgery at some point in their life because of a pelvic floor disorder, and half of all women suffer symptoms by the time they turn 55, and damage resulting from childbirth is the main indicating factor of why. So why is this damage occurring? We think it's perhaps a case of too much stretch happening too quickly. So we sort of judge the progress of labor on the sort of dilation of the cervix. And so the average patient spends about 14 hours during the first phase of labor. What's happening during that time is the baby's been living in uterus and starts contracting the baby's head down toward the cervix, and it takes about 14 hours for the baby's head to slowly open up the cervix. But the tissue that surrounds the vaginal canal where these pelvic muscles lie don't really dilate until the baby's actually coming through, in which case they go from 0 to baby, and that happens rather quickly. And so the concept is, what if we could take advantage of some of that time that a woman is spending during the first phase of labor and slowly prepare the pelvic muscles and vaginal canal for this delivery, remove the device, and when the baby comes through, hopefully it doesn't do the same damage. So we sort of got this idea anecdotally from obstetricians and midwives claim that whenever there was a precipitous delivery, so a quick delivery, there seemed to be more tearing. Obstetricians also, on occasion, have held the baby's head back to give the tissue a little bit more time to stretch, or the midwives often practice a technique where they don't have the mother push, again, to give the tissue a little bit extra time to stretch. So what we've developed is a mechanical dilator that would be used in the first phase of labor for about 30 to 90 minutes. You can see sort of where it's placed. The target is sort of the first half of the vaginal canal. That's where the pelvic muscles are injured. And you would remove the device, and the sort of benefit of that stretching would last for several hours after. So it's not like you need to do the dilation and remove the device and have the baby come immediately after. We believe that there's several hours of benefit from the device after. We have some animal studies that show greater than 4 hours. And there's actually one publication that proposed doing sort of what we're proposing to do. There's a researcher in South Africa that was concerned with obstructed deliveries, so babies getting stuck on the way out. And what he did is started the study with 30 patients, half in the device and half in the control group, where he dilated their vaginal canals with an IV bag, and he glued a touchscreen to the front of it because he thought that would help hold it. There was a significant decrease in the length of the second phase of labor and a decrease in the use of instrument deliveries. And so we think that there could be many value propositions for doing this preparatory dilation, preventing tears, preventing pelvic muscle injury, and perhaps you could have an easier, quicker delivery. So we've been using our device clinically now at a couple sites. One is at El Camino Hospital here in Mountain View, and the other, our primary clinical site, is in Houston with the Baylor Obstetrics Group. Our target is enrolling 30 patients, and we're at patient 28 so far. And to date, the results have been very encouraging. We followed up 20 patients at 3 months post-delivery with the pelvic muscle ultrasound, and so far we have yet to see a pelvic muscle injury in those patients. And as I mentioned, the injury rate is reported in the literature is greater than 30%. So now we are enrolling control patients to give us something else to control to. We seem to have a reduction in laceration rate as well. It's not zero, and so we don't. It's not as impressive as our pelvic muscle injury rate just yet. So those are the endpoints that we're looking at: pelvic muscle damage, laceration rate, and length of delivery is a little bit trickier to assess. When the mother started pushing, who's got the stopwatch ready, and so that's probably something that'll take some time to understand. So this is something else that many of you probably know, that childbirth is the #1 reason for hospitalization in the world. So we think that if we develop a technique, a device that has all the benefits that we hope it does, that this could become standard of care, which makes this